Our topic for today is shock. So what is shock? It is defined as a circulatory insufficiency. So it basically creates an imbalance between the tissue oxygen supply and the demand. First, we will be looking at the classification and the causes of shock. So first type we are going to be looking at is hemorrhagic shock. Hemorrhagic shock can happen due to traumatic or non-traumatic reasons. So traumatic. First comes traumatic. It could be blunt or penetrating injury, fractures of long bones and pelvis. Okay. So second is non-traumatic. It could be GI bleeds, peptic ulcer, gastric mucosal erosions, esophageal varices, typhoid bleeds, disseminated intravascular coagulation (DIC), aortic dissection, rupture of aneurysm of a large vessel are some examples. First type was hemorrhagic shock. Now coming to the second type, that is hypovolemic shock. So hypovolemic means fluid loss. So fluid loss could be because of vomiting or diarrhea. So vomiting or diarrhea, like in cholera, other GI infections. Fluid loss can also be found in diabetes mellitus, adrenal insufficiency, excessive sweating, exfoliative dermatitis, diabetes insipidus, reaccumulation of ascites even after tapping. Okay, so that was the second cause. Third one is sequestration of fluid, like in intestinal obstruction, pancreatitis, burns, crush injuries. Third type is cardiogenic shock. It could be acute MI, myocardial infarction, cardiomyopathy, cardiac arrhythmias, and it could also have mechanical causes like valvular disease, outflow tract obstruction, ruptured ventricular septum. Okay. Now the fourth type, that is distributive or vasogenic. It is relative hypovolemia. So first one we could take it as septic shock, toxic shock syndrome. B will be anaphylactic. C will be neurogenic. Okay, so shock is a progressive disorder. If untreated, it can go to severe stages. It could also cause multi-organ failure. So now we'll be discussing the stages of shock. Stages, there are 3. Okay, first one is early compensated shock. Early compensated shock, the vital organ function is maintained. How? By compensatory mechanisms. Though there is increasing tachycardia and decreasing BP, so hypotension. Okay, the skin is cold and clammy. Capillary refill time is increased more than 3 seconds. If there is delay in treatment, it would go to the next stage, that is decompensated shock. Decompensated shock, the BP falls, cardiac output also falls. Now there are features of peripheral poor perfusion, so vital organ impairment also starts to manifest. Now how does that manifest? First, if there is impaired cerebral perfusion, we get features of mentation. If there is renal hypoperfusion, oliguria. If there is coronary flow impairment, myocardial ischemia. Patient has acrocyanosis, cold and damp extremities, and a pale look. Okay. Again, if this is untreated, it will go to the next stage, that is irreversible state of shock. Irreversible shock is when hemodynamic correction does not halt the progressive organ failure. So irreversible shock leads to progressive organ failure. Okay. Coming to the salient features of shock, we have already come across some of them, namely tachycardia. BP may be normal or elevated due to compensatory mechanisms. Later it could fall due to cardiovascular complications. Okay, so there is a difference in the BP, or it could also be normal in the initial stages. So next comes neck veins. It may be distended or flattened depending on the etiology of the shock. We also came across different reasons for poor peripheral perfusion. So decreased coronary perfusion could lead to ischemia, decreased ventricular compliance, increased left ventricular diastolic pressure, and pulmonary edema are some other features. Tachypnea, increased minute ventilation, increased dead space, bronchospasm, hypocapnia. Okay, with progression to respiratory failure can also be seen. So adult respiratory distress syndrome can also be seen. We already have gone through points like skin becomes pale, dusty, clammy, and cyanosis, sweating, altered temperature, decreased capillary refill, olivera can also be seen. Coming to the treatment. Start the patient on oxygen 4 to 6 liters per minute. Airway control, endotracheal intubation, adequate venous access. Large bore peripheral IV catheters can be used for this adequate fluid resuscitation. Central venous access may be necessary for monitoring and employing pulmonary artery catheters, venous pacemakers, long-term vasopressor therapy. Next will be volume replacement. So we can use isotonic IV crystalloid fluids like 0.9% NaCl, Ringer lactate solution, which are preferred for initial resuscitation phase. Initial bolus volume is 20 to 40 ml per kg over 10 to 20 minutes. Okay. In other words, rapid infusion. Colloids like dextran, hetastarch, etc. can also be used till blood becomes available. So next is, as I told you, blood. Okay. So blood is the ideal resuscitative fluid when it comes to hemorrhagic shock and in the presence of significant anemia. Platelets are given when there is an ongoing hemorrhage and platelet count is less than 50,000. FFP is indicated if prothrombin time is prolonged, like more than 1.5 times. Next will be vasopressors. Okay, vasopressor should be used if persistent hypotension, even after adequate volume resuscitation. So we can use injection dobutamine. Okay, dobutamine how much? 2 to 20 microgram per kg per minute. If the systolic BP is over 100 mmHg. If the systolic BP is between 70 to 100 mmHg, the dose becomes 2.5 to 20 microgram per kg per minute. And injection norepinephrine can be used 0.5 to 30 microgram per minute if the BP is under 70 mmHg. So 2 to 20 microgram per kg per minute injection dobutamine if 100 mmHg over 100 if the BP is over 100 mmHg. 2.5 to 20 microgram per kg per minute injection dobutamine if the BP is between 70 to 100. If the BP is dropping below 70, injection norepinephrine 0.5 to 30 microgram per minute can be used. Now the eighth one is acidosis. Acidosis should be treated with adequate ventilation, fluid resuscitation. We can use sodium bicarbonate, 1 milliequivalent per kg. This is used only in cases of severe acidosis, refractory to ventilation and fluid resuscitation. Early surgical or medical consultation for admission or transfer is indicated. The patient should be monitored in ICU under special care units by careful continuous monitoring of BP, pulse rate, respiratory rate, urine output, mental status frequently. Sedated patients should be allowed to awaken, which is called drug holiday, daily to assess their neurological status and to shorten the duration of the ventilator support. Now we will be going through the management guidelines depending on the type of the shock. So first we will be looking at hemorrhagic shock, adequate ventilation and oxygenation. Provide immediate control to the hemorrhage. Initiate judicious infusion of isotonic crystalloid solution or colloid solution. I have already told you this. If it is delayed, whatever we have been discussing, with poor organ perfusion or a delay in hemorrhage control, you might as well start with PRBC infusion at the rate of 5 to 10 ml per kg. Treat coincident dysrhythmias, okay, like atrial fibrillation with synchronized cardioversion. Now 2 will be cardiogenic shock. Cardiogenic shock, you might provide the patient with oxygen and positive end expiratory pressure for pulmonary edema. Begin the patient on vasopressors again or inotropic support. So that will be injection norepinephrine at the rate of 0.5 microgram per minute and injection dobutamine 5 microgram per kg per minute. Okay. So your main idea is to reverse the insult caused to initiate thrombolysis, arrange percutaneous transluminal angioplasty. Okay, that comes after the immediate management. Consider intra-aortic balloon pump counter pulsation for refractory shock. Okay, now we go to the next type. Our next type is septic shock. Okay, septic shock again start with adequate oxygenation. Administer again crystalloid 20 ml per kg, like 0.9% normal saline or Ringer lactate solution, or 5 ml per kg of colloid. Okay, and titrate the infusion to adequate central venous pressure and urine output. you might also begin the patient on. So second one was crystalloid. Third one is antimicrobial therapy. Attempt surgical drainage or debridement. If hemoglobin is less than 8 gram per deciliter, begin PRBC infusion. If the volume restoration fails to improve this organ perfusion, you have to begin the patient with vasopressor support. So initial choice is injection dopamine. Infusion at the rate of 5 to 15 microgram per kg per minute. So that was about shock. That's it. Thank you.